Okay, well, thank you to Jeff and Shiv for a great conference, and obviously there are many people who contributed to make this happen, so really thank you to everyone. Really been a fascinating conference. It's almost a very interesting dialectic in this conference. On the one hand, we hear the applauding of confusion and complexity of the autonomic nervous system, and then on the other hand, the applause for the simplicity and trying to look at this in more simplistic ways so that we can make some better understanding and advances. And I think that, as you'll see, when diabetes, many of those concepts will continue on. So just very briefly, when cardiologists think about diabetes, I think the general point of view is that it's a line item in Table 1 in a study describing patient characteristics. That's about it. Patients with cardiac disease have diabetes. Usually it's around 20, 30%, and we don't relate much to it. Once in a while, we find somebody who's interested in writing a paper about diabetes, and you'll find an outcomes paper focused on patients with diabetes. What I hope to convince you by the end of this talk is that, particularly when we're talking about neurocardiology, diabetes should really be a carve-out. We really need to look at diabetes in a completely different way. And one of the important reasons that we need to do that is, first of all, because of the enormity of the problem. Just some basic statistics: over 280 million people worldwide, diabetes associated with about a twofold increase in mortality. Asymptomatic cardiac autonomic neuropathy and diabetes is found in at least 20% of patients with diabetes. So you're talking about 57 million people with diabetic cardiac autonomic neuropathy, at least out there in the world. And importantly, it's associated with a 3.5-fold increased mortality. Right now, there are really no therapeutic strategies that address this issue, and part of it, I think, is because it's very poorly understood. This is data from, I think, Framingham, looking at the percentage of sudden deaths in patients, looking at patients with a history of diabetes. And you can see that diabetes accounts for about 20% of all patients presenting with sudden cardiac death. Again, highlighting this as an important problem. I think we heard yesterday that diabetes is a separate risk factor, and just really to highlight that, this is a study that we did from our stress lab, looking at 3,000 patients that underwent stress testing. At the end of about 7.5 years of follow-up, there were 228 that were dead. 13% of them had diabetes. We were looking at a variety of different prognostic factors here. One of which was heart rate recovery, which is a standard technique that was developed at the Cleveland Clinic. And we stratified our diabetics and non-diabetics based on their heart rate recovery as well. And what you can see here is that heart rate recovery, if it's above 12, you have a good prognosis without diabetes. If you do not have diabetes and it's under 12 beats per minute, you have a lousy diagnosis. But look, if you have diabetes and your heart rate recovery is good, you have the same prognosis as those patients who have very low heart rate recovery. And obviously the worst group here is patients who have diabetes and low heart rate recovery. And you can look at study after study that has looked at this. This is another study looking at the outcomes after myocardial infarction in type 2 diabetes. And again, the type 2 diabetics do much worse. So the question is, what's the potential unique contributions of diabetes to this increased incidence of mortality and sudden cardiac death? And if you go through the literature, you can find a whole host of potential etiologies. And when you can find this many etiologies, you can be sure that nobody knows the answer. Our focus, though, is the question of autonomic dysfunction, cardiac autonomic neuropathy. And what I'd like to try to tie that into is the repolarization abnormalities that you see in diabetes, and see if perhaps the two of those can serve as a substrate for malignant arrhythmias in patients with diabetes. Interesting also, when you look at the pathogenic mechanisms for autonomic dysfunction in diabetes, many of these mechanisms were items that were discussed yesterday, oxidative stress, for example. But again, there's a whole host of potential etiologies here, and it's really not clear what the primary cause is for cardiac autonomic neuropathy in diabetics. Interestingly enough, even if you look for pathologic studies on cardiac autonomic neuropathy, the best that you can find is pathology in patients who have had advanced diabetes with peripheral neuropathy and advanced cardiac disease, and we don't really know what the nerves look like in early cardiac autonomic neuropathy. So as was mentioned earlier, there are a variety of different techniques for looking at autonomic tone, the variety of different heart rate techniques that were discussed earlier. In diabetes, the recommended set of tests are Ewing's maneuvers, which consist of a whole host. I keep having problems with this as well. There we go. A whole host of Ewing's maneuvers here that are basically provocative tests that look at changes in heart rate and blood pressure with standing and breathing maneuvers. And what we're going to focus on is testing that we've put together, an exercise-based testing for cardiac autonomic neuropathy. Now, before we get to our diabetics, I just want to present to you this set of studies that we did. These set of studies were done in normals. We took a group of normal subjects and we studied them on 4 separate occasions. They basically came for exercise testing on each occasion. The first exercise test was done without any drug infusions. On visits 2 and 3, when they came into for their exercise test, during exercise testing, we either administered atropine to achieve parasympathetic blockade or propranolol to achieve beta blockade, and then exercise 3 was done with the other agent, and then this 4th session was done with double blockade. And the idea here was we wanted to use these as probes to look at the autonomic effects that we could see during and after exercise. So these are typical tracings. This is looking at the RR interval. Easier to stand over here. And I know why everyone was moving away from there. So anyways, so this is looking at the RR interval, which is just the inverse of the heart rate. And the baseline test is in red, yellow is the beta blockade, white is parasympathetic blockade, and blue is double blockade. So you can see at the very beginning of exercise, the RR interval decreases or the heart rate increases, and basically for all 4 sessions, the heart rates are essentially the same. If you look at the red is the baseline, so this is what happens with persistent exercise for about 22 minutes, and then this is the recovery. So there are 2 groups that received propranolol, and it was started here, and you can see that when you, the groups that received propranolol, the blue and the yellow, they have a lengthening of the RR interval, as you would expect. And the 2 groups that received atropine was administered over here, and you can see that compared to the baseline, if you get atropine, it shortens the RR interval, just as you would expect. And then here in the beta blocked patients, you give atropine, it shortens the RR interval. And then we can look at the RR interval recovery. All right, so why did we do this? So what we were really interested in looking at is to define the QT-RR dynamics that are occurring after exercise in recovery. So remember that sudden cardiac death, one of the main precipitants for sudden cardiac death is exercise. You have anywhere between a 10 and 70-fold increased risk of sudden cardiac death during the period of exercise or the 30 minutes following that. And a lot of our testing is done at rest when we do risk factors. And the question is, could we do better by doing some sort of provocative testing? It's like the old ECG. It's not a very good test to detect myocardial ischemia in a patient with stable angina. But you put them on the treadmill and then use the ECG, all of a sudden it becomes a much better test. So the question was whether we could design a test that would look at cardiac repolarization in the setting of exercise or recovery. Exercise is a little difficult because you get a lot of noise when patients are exercising, but in the recovery period, we actually get very nice tracings, and we have a dynamic change both in the QT interval and in the RR interval in recovery. And then we can define, basically, we can plot the slopes. We can plot the QT interval versus the RR interval. This is just summary data. But essentially, this would be in the red, the QT-RR slope for normal patients without any drugs. And we can look at the effects of autonomic blockade on the QT-RR slope. So for patients who are given beta blockade, it flattens the slope. For patients who are given parasympathetic blockade, it makes the slope much steeper. And for patients who get double blockade, it's essentially superimposable. So if you just imagine, if you just look at the QT interval at a fixed RR interval, let's say it's 600 milliseconds, so beta blockade will shorten your QT interval, and parasympathetic blockade actually lengthens your interval, your QT interval, which means that the parasympathetic tone is working to shorten your QT interval. So it's an antiarrhythmic effect. And your beta blockade is shortening it so that the beta adrenergic activation is actually lengthening your QT interval. So this allowed us to then revise our protocol. You can see the biggest effect that you see in terms of QT interval is the parasympathetic blockade. So we shortened, it's very cumbersome to bring people back for 4 exercise tests with all this autonomic blockade. So we used this data to basically shorten our testing to be just a baseline test and then a repeat test with atropine. And then just to highlight again, as we go and talk about the diabetics, QT prolongation has actually been very well described in diabetics, prevalence of 20% in the diabetic population. In patients who have cardiac autonomic neuropathy, its prevalence is over 30%. It's associated with all-cause mortality, cardiac mortality, and sudden cardiac death. And we thought that, therefore, between all the findings that we have, exercise, sudden cardiac death, risk of sudden cardiac death, and diabetic cardiac autonomic neuropathy, that these should all be integrated and perhaps provide some sort of rational basis for this. And this is also data from that initial study that I showed you from our stress lab. We looked at the QT-RR dynamics, and again, showing this is looking at QT-RR dynamics and heart rate recovery. But you can see that QT dynamics also tend to, you have a worse survival if you have abnormal QT-RR interval. All right, so moving then on to our diabetic study. So we first decided that we'd study type 2 diabetics. We had 18 diabetics and 20 controls. These were very carefully chosen diabetics. These were patients who all had some sort of exercise in their history. They were able to exercise, no angina. So it's a very select group. We have to remember that. Very well-controlled A1Cs, duration of diabetes about 5 years. And I said we're now down to 2 exercise sessions, one without drugs, and then the second one with atropine. So again, this is now a typical heart rate trace during this exercise. So that we do 5 minutes of recording at rest. They start to exercise, and it's a 16-minute period of exercise on the bicycle. They do 4 minutes at about 50 watts. Then we increase it to 75 watts and 100 watts if they tolerate it. And then we record their RR intervals and their ECG, their 12-lead ECG, for about 45 minutes into recovery. So this is demographics of the population. You can see both controls and the diabetics are around 55. And these are have a fair amount of other diseases, but generally doing a diabetic group that's doing fairly well clinically. Peak exercise workload was the same in the controls and the diabetics. Peak exercise heart rate was the same. And then here is the R interval trace for basically the 4 groups. So we're talking about in the solid squares here are the controls, and these are your diabetics. And you can see that actually during exercise, the controls and the diabetics, their R intervals track almost perfectly until this point where atropine is given, and then both groups have a shortening of their R interval. Interestingly, you'll notice that both the diabetics and the controls have overlapping R intervals after atropine. And then the striking difference is the R intervals that occur in the controls versus the diabetics. So you can see the diabetics have a much shorter R interval in recovery. So we quantified this parasympathetic effect by just looking at the difference between the R interval without atropine and the R interval with atropine. And that's shown on the next slide. So you can see in the controls, you have this parasympathetic effect, about 220 milliseconds or so, and then the diabetics have a significantly depressed parasympathetic effect in recovery. We also looked at plasma catecholamines at various points during exercise and recovery, and you can see here this is the controls, this is the diabetics, so they tend to have a little bit of a higher peak and a little bit slower recovery in their plasma norepinephrine levels. And this was very, very interesting. We then looked at the controls and the diabetics, and we looked at the relationship of their heart rate recovery to the parasympathetic effect or to the recovery in plasma norepinephrine. So let's look at the controls down here first. So it's thought that the heart rate recovery is predominantly due to parasympathetic reactivation. And you can see in the controls, there's a very good relationship between the heart rate recovery and the parasympathetic effect as we defined. So that would be as you would expect. And there was no significant relationship between the heart rate recovery and norepinephrine and recovery of norepinephrine levels. Interestingly enough, this was completely reversed in the diabetics. In the diabetics, there was no change, there was no relationship between the heart rate recovery and the parasympathetic effect, but there seemed to be a relationship between the heart rate recovery and the change in norepinephrine levels, suggesting that there may be a change in the control of the heart rate in recovery. Now, the one thing that you would ask me, or we asked, is, well, are the diabetics different than other patient groups with heart disease? So fortunately, we had already previously studied a fairly large group of patients with coronary disease, patients with both preserved LV ejection fraction and patients with depressed LV ejection fraction. And the data are here. We actually found no significant difference in the parasympathetic effect between controls and CAD patients, whether or not their EF was depressed or not. So this really suggests to us that the defect that we're seeing here in diabetics is unique. It's not a marker of general heart disease. So something different is going on. So once we've done studied our type 2 diabetics, we said, all right, well, let's study type 1 diabetics. We sort of thought that these people would have more advanced disease, and we'd see even greater problems in their parasympathetic effects. So we studied 16 type 1 diabetics. We studied some additional controls because the type 1 diabetics are younger, so we needed a little bit, some added controls. And you could see that the type 1 diabetics had a much longer duration. This just indicates we looked at their peripheral neuropathy scores, their Ewing scores. They were all fairly low, so really not much evidence of neuropathy. Resting heart rates were a little higher in the diabetics than the controls. The peak workload during exercise was identical. Peak heart rate was virtually identical, and this was their resting QT intervals. So this is what we saw. This is now, again, looking rest, exercise, and then recovery. The controls are in blue. The green here represents the type 2 diabetics, so this is the same data that you looked at before, but you can see that the type 1s are essentially superimposable with the controls. They don't look at all like the type 2 diabetics. When we quantify the parasympathetic effect, you can see here the type 2 diabetics, there's a little bit of a depression in the type 1 diabetics, but not anywhere what we see here, and this was only borderline statistically significant. What was interesting, if you look at the norepinephrine levels, so again, these are the controls. The type 2 diabetics had this exaggerated response and slower recovery. The type 1 diabetics have a completely different pattern. They start off with a very elevated resting norepinephrine level. They have less of an increase, and then they have persistent elevation in their plasma norepinephrine levels in recovery. Again, a completely different pattern than what you see in the type 2 diabetics. So this is just a plot of the QT intervals over time, and essentially we looked at the QTRR slope among the groups, and it turns out that there was absolutely no difference in the QTRR slope between the controls, the type 1 diabetics and the type 2 diabetics, and no change with atropine either. So even though we could identify autonomic abnormalities that affected the sinus node, we could not, at least with this technique, identify any repolarization abnormalities. So what we concluded from this is that exercise and parasympathetic blockade can uncover some early autonomic abnormalities in diabetes that you would not otherwise see with other techniques. We also identified that there's a different pathophysiology for cardiac autonomic neuropathy in type 1 versus type 2 diabetes, where type 1 is characterized more by sympathetic abnormalities and type 2 more by parasympathetic abnormalities. It's a change in the nature of the relationship of heart rate recovery to post-exercise autonomic changes. And finally, early cardiac autonomic neuropathy in healthy diabetics is not associated with abnormal QTRR slope in early recovery. But I don't think it's fair to conclude a conference like this with conclusions. I think it's better to conclude a conference like this with questions. And I think these studies have really raised a lot of questions in my mind. First of all, which abnormalities related to CAN are associated with the worst prognosis, those of type 1 or type 2 diabetics? Is it better to have or worse to have depressed parasympathetic effect or increased sympathetics? Are any of these early abnormalities treatable? One of the things we talked about before, and that we'll get down here, is, could some of the nerves be sick? I mean, are there pathologic changes in the nerves, and are they treatable? And is it possible that some of the diabetics have neuropathic changes, whereas in others it's physiologic changes due to other concomitant issues like insulin doses, for example? Do early CAN abnormalities predict later development of repolarization abnormalities and sudden death? It's possible that we're catching these people so early that they're compensating and they don't have repolarization abnormalities yet, but this is maybe the right time to actually catch them and treat them. Again, these are things that we have no idea. And I think it's very important how to develop gold standards for the diagnosis of CAN and diabetes. The literature is all over the place in terms of techniques. And until we have some sort of better way to define what it is that we're talking about, it's going to be very hard to study any further. And I'm sure there are many more pages of questions, but I'll let you ask them. Thank you.